took today off.
Okay, excellent. Good
No rush.
morning.
Good morning. How are
Oh,
you?
I'm good. How about you?
I'm doing great. Thank you very much for inviting me to chat today.
Thank you. Same. I was going to ready to say the same thing. So the recording is on. I ask two questions. I ask you to tell us your name and share anything about yourself you feel comfortable sharing. So let me start with your name. Please tell us your name.
Okay. My name is Sharon Marshall Ying,
Okay.
and I am a registered nurse, actually by training, although I currently work in the pharmaceutical industry.
Okay. Thank you very much for that. How long have you been a nurse?
I graduated as a nurse from Durham Tech in 2005.
Okay.
So 16 years. Oh my gosh, 16 years this year. I've been a nurse for 16 years. Wow.
Wow. So let me ask you this, and start with current affairs. So we hear a lot about the strain on nurses and other medical professionals with COVID. How has that impacted you? How has COVID and your work and your efforts, how has it impacted you?
Um, I do not work bedside right now. So from a direct bedside care, it didn't affect me significantly in that sense. From a volunteer perspective, I did have the opportunity to volunteer for like vaccine clinics.
Mhm.
When the vaccines first came out, I was able to help administer them, which I thought was wonderful, especially to see so many 16, 17, 18-year-olds come. In addition, um, as part of my career, I work in a department called medical communications. And I was able to spend several months gearing up for the release of one of these vaccines, training staff, preparing staff, so that we could adequately educate patients and healthcare providers on how to safely store, safely mix, safely administer these vaccines. And it's that was hard. That was a lot of work, and the data was constantly changing. But very few people get to say that they help save the world, right? So
Okay. Thank you for saving the world.
no, it wasn't just huge group effort. I had one little piece.
Well, thank you for your work too. So let me ask you a question. The other part that's come out of this COVID story is the number of nurses and people in the medical profession leaving the profession. I guess because of the strain and the amount of hours and all of that you do. How do you center yourself in the middle of your work to stay on point and sharp in what you do?
So I think it goes back to everything feeling so overwhelming.
Mhm.
No, I can't do this all. I can't fix everybody. I can't fix everything. But my center is finding the thing. If I can change one thing for one person, then I've made a difference. My reason for being on this earth is to help serve other people. I'm not going to be able to serve everyone, but if I can make somebody's day better, their job easier, if I can give a vaccine and help protect them from a deadly disease, then I have served my purpose for
Okay.
that day. And I still have accomplished things. Even if I have a to-do list that still has 99 things on it, that's okay. Because I have still accomplished what I was put on the earth to do.
Excellent, excellent work. So did you know you wanted to be a nurse all your life, or was this something you discovered
No,
later in your life?
absolutely not. So I was I'm originally from Delaware. So I was born in Wilmington, Delaware, and grew up in Newark, Delaware, which is where the University of Delaware is. Um, I grew up very financially insecure. Um, my father had a high school diploma. My mother had about a sixth grade education,
Mhm.
and actually taught herself how to read again. She was functionally illiterate for most of my life. So my parents' goal was for me to graduate high school without having a child. That was, if I did that, like college off the table, like that's not happening. So you're going to need to graduate, you're going to need to find a job. I said, okay. And I did that. I moved out when I was 18, and my parents weren't, cruel people. This was just the way they were raised. And, so I did that, and I found a job. And a few years later, I had a boyfriend who was going to come to Duke University for graduate school. And I said, you know what? Kind of seeing where I grew up and what the process is, and I'm going to move down to North Carolina with you. sight on scene.
Mhm.
Let's go right now.
Very brave.
And unfortunately, while our relationship did not work out, and he's a wonderful, wonderful man, our relationship did not work out, but my love for North Carolina did. So I stayed here, and I was taking classes at Durham Tech, and I didn't know what I wanted to be when I grew up, because I'd never really, like, the goal was to graduate high school, and I did that.
Mhm.
So as these stories often go, I meet another guy, I get pregnant, and I'm at Durham Tech, and I'm holding my toddler on my lap, and I'm talking to one of the guidance counselors, academic advisors, I should say. And he goes, well, what are you going to major in? I'm like, I don't know. Like, I like taking these classes and this. And the gentleman's looking at me, and he points to my son, and he's like, you have a baby. By your own admission, you're unmarried. While you are with the father of that baby, he does not provide consistent support. You need to have a career. And he looks at my transcripts, because I had already taken several classes at that point. And he goes, you have really good math and science scores. Have you ever considered being a nurse? And I went right away. I went, nope. I said, they're overworked and they're underpaid. And he says, they're employed, and that's what you need to be. And I went, okay, that's fine. What's it going to hurt? I can go into nursing school, and at Durham Tech and at many nursing schools, you have to take a CNA course, a certified nursing assistant course first.
Mhm.
It's like 12 weeks, and they make you take that before you go to nursing school, because so many people would start that first semester in nursing school and be like, not for me, I'm leaving. So this was kind of a way to get your feet wet. And I took that CNA class, and I loved it.
Excellent.
I loved it. I loved it. I loved learning about the medical aspect. I loved taking care of people. And I was like, you know what? This may be for me. And again, I need a job. So I went ahead, and I had to work full time while I was in nursing school. I do not recommend, but worked full time at the time as a health unit coordinator, like a secretary in the ICU. So I would work Friday, Saturday, and Sunday, 12 hours shifts overnight. And then I would go to school Monday through Friday.
Mhm.
And I had Wednesdays off. So I spent a lot of time just studying and working. And I did it. So made it out in 2005 and started working on the same unit I had been a secretary on. So I became an ICU nurse, and did that from about 2005 till about 2009. And that's when I left the bedside.
So let me ask you this. If there was some young woman or young man comes up to you and says, Sharon, I would like to be a nurse, or I'd like to be in the healthcare profession, what would your conversation be? How would you start with them? How would you encourage them? And what would you recommend for them?
I actually get this question a lot from people when they find out that I'm a nurse. And I say to them what I'm going to say to you now, which was, becoming a nurse was the best decision I ever made.
Mhm.
Is it hard? Yes. Are we overworked and underpaid? Also, yes. However, it was still the best decision I ever made, because not only for what I learned at the bedside, and not only for serving my purpose, but also for the doors that it opened for me. Even when I left the clinical setting, because if you're a nurse, it's like having been a Marine, right? Like, it is attractive to employers. They know you have critical thinking skills. They know you can work under pressure. So first, I say it's the best decision I ever made.
Mhm.
Next, I often recommend volunteering if they're interested in going into, because most people, when they say they want to be a nurse, they want to go work at a hospital. That's what we think of when we think nurses. I recommend that they volunteer at a local hospital for two reasons. One is it kind of gives you that exposure. Nursing school is a really, really, really intense and can be a very expensive experience.
Mhm.
And you don't want to go into that blind.
Mhm.
So you can volunteer at a hospital. When I went to nursing school, I volunteered at a hospital because I could not afford all of the vaccines that were required.
So as a potential nurse, you have to have a lot of you have to take a lot of vaccines
Yeah, well, you have to be up to date on, your MMR and all
Yeah.
these other things. But at the time, because of the way, our healthcare system works, if we want to call it working in the US, I would have had to pay for a lot of these vaccines. But because I volunteered at a hospital, the hospital paid for all my vaccines. So I often recommend that people volunteer at a hospital. It's not a huge commitment. You do your orientation, you get your vaccines, and you can volunteer 4 hours a week. But it kind of gives you that exposure to what the hospital setting is really like. Because you may do that and be like, oh, this isn't what I want to do at all. But if you do that and you're still interested, I let them know that most nursing schools will let you take, will want you to take a CNA class, and that you just have to be comfortable listening to people.
Mhm.
So you're a nurse, and it's not just your patients, it's the doctors, it's the patients' families, it's social work. Like, it's not always going to be your way.
Mhm.
And if you're comfortable with that, if you're comfortable with listening and adapting, if you're comfortable with some of the less glamorous aspects, there's blood involved, there's other body fluids involved.
Right.
And you can do a couple of years clinically and you can get that done. Nursing will open so many doors for you that you didn't even know existed.
Wow. That's wonderful.
Absolutely. So anybody who's interested, I absolutely encourage them to explore it, but get your feet wet a little bit. Make sure it's really what you want to do before you make that kind of investment.
Thank you. Is there an age limit? So is this more for younger people or anyone should consider?
I remember when I started my nursing program, I was in my late 20s and I thought I was going to be the oldest person at school, and I was probably the second youngest. A lot of second career people. I went to school at Durham Tech with somebody who had used to be a truck driver. I went to school with somebody who had been a chemist, computer programmers. Lots of second career people decide to go into nursing. So no, there's no age limit on caring. I mean, you have to be comfortable with the science, you have to be comfortable with technology, and there's no age limit on that either. So
Excellent. Thank you so much for that. So a lot of the things we heard, bring up COVID again, a lot of things that we heard was about nurse pay. So that when COVID finally hit, it gave a pay bump to nurses because of the amount of stress and strain it takes to work in that role. And you still say that you work harder and get paid less. So a lot of the foundational things in nursing has not changed.
the foundational thing in nursing that makes it so hard from a pay perspective is when you look at how reimbursement structures are set up in the US healthcare system. A doctor bills for their time.
Right.
I see this patient, I bill for that hour. Physical therapy bills for their time. Occupational therapy, speech pathology. Nursing is wrapped up into a room charge when you think about it, or a supply charge.
Got it.
So when hospital administrators are looking at physicians and physical therapists and nurses, when they see these other providers that can bill, they're an input. You're going to get money in for them. When they look at nurses, nursing is all red, right? We're just paying nurses, we're paying nurses, we're paying nurses, but we cannot bill for the care that nurses provide. And that's the fundamental. I mean, we can go through all the other macroeconomics of healthcare.
That's the obvious.
Fundamentally, that is the problem with nursing. And then historically, when you think of the nursing profession, and we have our Florence Nightingale. She was a statistician in addition to being a nurse and all these other things. But there was a time in our country when people became nurses because they had been arrested, and their choice, they were prostitutes. There were places in our country where when women who were sex workers because they had no other alternative and they were trying to make money were arrested, they were offered jail, or they could go become a nurse and work in a hospital. So you have a history like that, which doesn't garnish the most amount of respect. Now, I'm a proud community college graduate. I did end up going back to get my bachelor's of nursing at UNC Greensboro. But I'm a proud community college graduate. But it's also very confusing for other healthcare providers to understand, because for nurses, the entry into practice, you can be a diploma nurse and pass your NCLEX and get a license. You can be an associate degree nurse, pass your NCLEX and get a license. You can be bachelor's prepared. You can be a master's prepared nurse. There's a lot of educational pathways to nursing, which is great. But then other providers aren't sure where you're coming from. What was your educational preparedness?
Yeah.
So it's complicated. It's a complicated history, but fundamentally, it's how we bill for nursing care, and that is we don't. It's red. It's all wrapped up into the room charge. So you have to charge enough to recoup what they consider an outflow of paying nurses.
So let me ask you this. So in the grand scheme of things, with all of that that's there, do you think nursing will change in that nurses can get paid or be billed their services out? So in other words, so let's just say I am going to a clinic or outpatient thing where there are nurses and other health practitioners there. Their stuff is still billed that way too. So it's still billed as a part of your visit to that clinic, as opposed to there being designated funds in that visit for the nurse.
Unless you're an advanced practice nurse,
Mhm.
which is a little bit of a different scenario, because we have advanced practice nurses providing, family health care, general practitioner care, things that are not very lucrative for doctors who have those kind of medical school bills to go into doing. Advanced practice nurses can often bill for their time. Um, I don't think the education is going to change anytime soon. There are a lot of forces at work in the sense that, like, if we suddenly made bachelor degree the minimum entry into practice for nursing, our nursing shortage would be even worse.
Wow.
There's not enough people to teach people. But then when we talk about it, how much of a nursing shortage do we really have? Do we have a shortage of nurses, or do we have a shortage of trained nurses who are unwilling to work in the hospital because of the pay, the workload, the acuity of the patients? The patients are much sicker than they used to be. And I think that there is definitely a value to having patients recover at home when they absolutely can. But then what's left are much sicker patients. There is actually chatter right now because, as you may have read, a lot of nurses have moved to travel nursing.
Yeah, I've
So
heard.
travel nursing historically is when you had like a shortage of nurses in a certain area. Hospitals would pay them very attractive rates, really attractive rates to come and travel there and work there. My husband, coincidentally, is also a nurse, and he was a travel nurse for some time. And travel nursing has really exploded in the pandemic because the pay is so good. Because at the end of the day, when you have patients lining the hallway, you need to pay people to take care of them. And there has been some chatter about trying to, I believe, pass a federal law that would limit the amount of pay that they could pay travel nurses. And
Wow.
I'm like, I'm not so sure that's the best plan. I think our reimbursement system's already kind of messed up enough, but that begs the question: could we always have paid nurses more, and we just chose not to?
Yeah. Let me ask you this question. Do you think there's any correlation to nursing? Well, nursing used to be predominantly women, and I think inherently in our society, women are paid less than men sometimes for equal work with equal experience. Could it be gender related, or do you think that's just how it evolved in the healthcare system? The people with the MD behind their names wanted to have the most money, so they carved out a system where those are the people who make money, and all the rest of the people just get what's left over.
I'm sorry. Could you repeat that question? I didn't quite follow.
Do you think a part of the problem is that most nurses, or at least were mostly women, and
Yes.
then that historically we haven't paid women well and fairly ever? And so, or is there a component where the person with the MD behind their names carve out so much of the money, there's not enough left for the rest of the people? Which of those things do you think is more likely to apply to the issue in nursing?
I do think that there's definitely a difference in professional respect from payers and from the public for an MD versus a nurse. I think what medical doctors do is invaluable. Nursing and doctor, being a nurse and being a doctor are two totally different things. And both of them serve to take care of the patient. And sometimes people break this down, that, doctors cure the disease and nurses take care of the patients and all this, but that's not really true. I mean, doctors care about patients as well. I think for a very long time, not only in our country, but in a lot of countries, they've been able to pay nurses a low rate. And some of that is historically, it was considered women's work. What else is women's work that we don't pay a lot for?
Teaching.
Like domestic care, teaching, all of these things that are historically women's work are also historically lower paying.
Yeah.
Again, I mentioned my husband is a nurse, and he graduated 1 year after me. And we have worked similar jobs, ICU jobs. He briefly worked in the pharmaceutical industry. He does healthcare IT right now. And on a very micro level, we've been an example of pay disparity. My husband has always made more money than me. no matter where he worked. Even when we worked at the same institutions, he made more money than me. But he negotiated, and women are acculturated not to negotiate. We're just supposed to be happy you're offering us a job, right?
Right.
If you're giving me a job, I'm not going to argue. And so, but he always negotiates and he always gets more money.
And that's a very interesting thing. I talk about that a lot, the art of the deal, right? So you know, we often are so excited that the company wants to hire us or sees value in us that we start devaluing ourselves almost immediately, right? I'm so happy to be at this company. I'm so happy I have this job.
I'm so happy you picked me.
Right.
Yeah.
But in reality, what's happening is this is how I think pay disparity grows. It's because women go into a field. I'll give you my really basic example. So I went to Duke in 2008. I became the IT person for the law school. In 2008, I was hired as a contract because they had a bunch of problems and they needed somebody to come in and help with that. About maybe 3-4 months into my job, I thought we should hire someone that's really technical, a really technical manager, a person who's really technical. So we found this wonderful guy, college degree, 10 plus years of experience. At the time in 2008, I made $79,000 a year. We hired him, I want to say in November. Remember, I started in June, so November at 80 something.
Oh yeah.
By the time we had left our mutual jobs, he was making $130,000 and I was making 90. And then I got the closest I've gotten to him is 123. That's as close as I've gotten. I have 40 plus years of experience. I have 4 college degrees. I'm a doctor. I have all of these things, but I still was paid less. And it's not ever clear how they make these distinctions on how they pay women so poorly. So one of the things I've learned about HR, which is why HR is always one of those places that seems to be the least transparent to me, is that it in reality is that working title. So your official job title, what you're hired on as a IT expert, but your working title is helping people IT work person. And so because you're at this title, that client service, which is insane to me, the people who are thinking ideas in the background get paid more than the people that are actually working on the clients, because they're the ones who keep the clients, retain the clients. And I think that's similar in nursing, right? You all get the patient to help. So the doctor comes in, performs surgery, doctor comes to bedside and says, oh, everything went well, see you. And for the rest of your care, you're seeing nurses and other specialists, blood people and all that stuff. Do you think that that's a reasonable approach to understanding pay disparity? Or do you think we should start empowering women or anybody really to negotiate almost any job that they go for? Sorry, that was wrong.
I think we should empower everybody to negotiate. I think our lack of pay transparency, which is a cultural thing in the US, this lack of pay transparency, like no one ever wants to talk about, like if somebody came up to you and just said, oh, hey, we just met, how much do you make? Most people in the US would be really taken aback by that. I think everybody should be empowered to negotiate because you should be paid your worth and not just paid the minimum amount that you feel a company can get away with paying you. So after that experience that I saw my husband, negotiate, every time I've been offered a promotion, I have negotiated my pay. And one time recruiting said, oh, well, we don't really negotiate for internal promotions. I said, well, then thank you very much for the opportunity. And I'm not going to accept the job. And they said, well, wait.
Right.
Wait, we'll go back, we'll ask. But yes, I think we should, especially women, because we're not cultured to do it and it feels uncomfortable. Because if a man does it, they're assertive. And if a woman does it,
you're aggressive. Right.
She's aggressive or she's complaining. And so I think we need to be uncomfortable. We have to go to those uncomfortable places so that we can do the best for ourselves, but not only for ourselves. I'm an associate director, so I've grown into a leadership position. I recently had a job offer for a manager, and I told recruiting, we're like, okay, what's the pay scale? What's she coming in with? This is the minimum I want to offer her, at a minimum, because it's what she's worth.
Mm-hmm.
But I'm absolutely willing to go up because I want her in this role and she deserves it. And she did. And the recruiter said to me, you are the only woman leader that tells me they want somebody to negotiate.
Yeah. Excellent. That's beautiful. Great work too. Thank you for that. Okay, so my next couple of questions are about the types of nurses. So there's something called a nurse practitioner, which I assume is a nurse doctor. That's what I can guess that is. And there are different types of nurses who do, and I don't want to say different things, but like a charge nurse or the supervisor doesn't seem like the right word, but the person who kind of coordinates and makes sure like there's, so what I do remember is like nurses usually start like, especially in a hospital, old dark early, and they have a meeting to transition from this shift to the next shift. What's the difference in the roles of nurses with, like, I understand seniority and experience and all that, but what's the different roles and titles within nursing, and why do they need to be there, and why do they matter?
And why do they what?
Matter. Why does it matter whether you have a BSN or RSN, whatever? I mean,
Well,
I don't know. Okay.
yeah. So, and this is one of those confusing things about nursing that I think makes it so hard to kind of rally behind nurses, because we kind of create these almost divisions amongst ourselves. A lot of this has to do with historical needs for nurses, particularly in things like wartime, when you needed to fast track people. So if we're thinking of hospital nursing, which is a lot of what you were talking about, when we're thinking of hospital nursing, most nurses that you see, if you were in the hospital or a loved one in the hospital, most of the nurses you see are RNs, they're registered nurses. Sometimes we have LPN or LVN, and those are licensed practical nurses. A licensed practical nurse usually has a little bit of a shorter training. And it depends on the state, but there's usually like two things. I want to say in North Carolina, there's only like two things that a licensed practical nurse can't do that an RN can do. And that's like push IV medications or give blood. So a lot of time, but LPNs make a little bit less money because those only seem like two things, but you give a lot of blood and you push a lot of IV medications in hospitals. So a lot of times LPNs may have more limited work opportunities. They may be in long-term care or like at a doctor's office, things like that. But if you're in the hospital, we're talking about a clinical setting. So almost all of the nurses you interact with that are bringing you medications and are doing your assessments, those are registered nurses. So they have gone through an accredited nursing program. They have passed our licensing exam called the NCLEX, which stands for something very long. I can't remember offhand. National something licensing examination. Your registered nurse that's taking care of you may be board certified. In med-surg nursing, they may be board certified as a CCRN, which is an ICU credential. They could be a woundostomy certified nurse. So they have some experience and they take a test and they get this certification. Sometimes you'll often work with patient care techs or certified nursing assistants. And again, I described that before. That's more like a 12-week class where you're taught how to take vital signs and you can help with personal care, but they're not licensed professionals. So work can be delegated to them, but still very, very incredibly valuable member of the team because they're doing a lot of the hands-on care. In the hospital setting, a charge nurse for a unit or for like a ward or the floor, sometimes they'll have a patient assignments and sometimes they're just coordinating which nurses are taking care of which patients, which admissions are we going to get, which nurses are those admissions going to go to. They're helping discharge patients. They're helping with transportation if patients have to go to test or move to another room, those kinds of things. A house supervisor is typically a nurse, and they're more of a general bed control. So it's not just one unit they're concerned with, it's all the units. So if somebody needs to come to the ICU, are there any ICU beds? And if they're not, is there somebody we can move to a step down so we can get that ICU bed free? Nursing managers are devoted to units and they're exactly what they sound like. They're, they people manage the nurses on those units. And again, they may have a credential like a nurse executive board certification. Then you get into that kind of APRN, those advanced practice registered nurses, and those are your CRNAs. You can be an advanced practice registered nurse in gerontology. FNP is family nurse practitioner. You can do neonatal nurse practitioner. There's a number of different areas you can go with that. They are at least a master's prepared nurse. So they've already gotten their bachelor's, then they've gotten their master's degree. And then of course we've always had a PhD, well, I shouldn't say always, for a very long time, we've had a PhD credential in nursing. Often that was nurses who'd gone into academia, would get their PhD. But we also have a DNP now, a doctorate of nursing practice, which of course is postmaster. So that credential is designed for people who are still performing clinical patient care. So
Excellent.
again, they've received more training. Again, they are typically board certified in whatever their specialty is. In North Carolina, advanced practice registered nurses can practice. It's not truly independently. They have a doctor backup.
Mhm.
But in some states, advanced, APRNs can practice independently. So there's currently, and it's called the SAVE Act that's kind of winding its way through the NCGA, which would allow advanced practice nurses to practice to the full, scope of their abilities. Because right now they do have to have basically an MD or a physician backup.
Excellent. Okay, so tell me this. Tell me, what does Sharon Ying do as a pharmaceutical nurse? Describe your work and what does a day in your life look like?
Oh my gosh. Oh my gosh, the day to day. So I work in medical communications, and to give a very basic overview of what that is, have you ever seen an ad for a pharmaceutical product?
Every
Right.
day, every minute of every day.
Every day, everybody sees the commercials and it tells you how great this product is.
And
But
it'll kill you if you take it.
also, you could have all these potential side effects. Or if you have questions about this product, you should talk to your doctor, or you can call us.
Mhm.
So because in the US, we allow what they call DTC, direct to consumer advertising for pharmaceutical products, every pharmaceutical company has to have a way you can reach them to ask questions, either you as a patient or your doctor or your pharmacist or your nurse, anybody. And so what I do in medical communications is we're the people behind that phone number.
Okay.
Pharmaceutical companies will retain us. So we hire nurses, we hire pharmacists. We also hire people who may not have a HCP degree, but they may have like a degree in a life science, like
Mhm.
biology, anatomy. And what we do is we're the voice on the other end of that call. So if a pharmacist wants to call and ask if it's okay to mix two medications in an IV line, we'll look up that information for them. If a patient calls and they want to know if they should take this medicine in the morning or at night, then we look at the available resources and we give them an answer for that if there is one. The FDA is very, very particular about what we're allowed to say and not allowed to say. We don't want to interfere at all with the patient-physician relationship. So that may be limited how much we can help patients, because that drug may not be the best thing for them, and it's their clinician who needs to decide that. But if we can help in other ways, then we certainly try to. We certainly want to help them out. So that is the basics of what we do. So I say telephone call because that's the most common, but we answer emails or chats or forms that are submitted online through the pharmaceutical companies' websites. So as an associate director, I have operations managers who report to me, quality and training specialists who report to me. And then we have our frontline staff who report to those managers. Gosh, my day to day, my daughter asked me, I have a 9-year-old daughter, who's my youngest child. And she said, do they pay you to go to meetings all day?
Great question.
I said, I think so. I think a little bit. So I work very closely with our clients because I told you the FDA is very picky, and they should be.
Mhm.
I know a lot of people get frustrated with the Food and Drug Administration, but their job really is to protect patients. So I work very closely with clients, not only to ensure that we have appropriate staffing to take care of all their customers, but to make sure that we have the appropriate resources so that we can answer those questions truthfully, that the answers we give are balanced. We're giving you the good information and the bad, if there is any, and that our staff is well educated on their products so we can provide that kind of information.
Excellent.
So it's the people management. So it's working with the client, but then it's my people management as well. So I work with my operations managers, my quality and training specialists, my workflow management associates, to make sure that they have the information they need, the education and the support, so that, because again, to go back to what you said, it's the frontline staff who's doing all this work. So if I'm not supporting my managers in the way they need, they can't support our frontline staff, and we'll have attrition, and then everybody's going to have to work way harder. I don't want to do that.
Thank you. Thank you for so much of this. This is my last question. And if there's any time left, you can say whatever you want to say that we didn't cover. But are you eventually going to teach, or is that a part of your future to pass your knowledge on to others?
So I spent many years after I got my bachelor's in nursing trying to figure out what I wanted to get my master's in nursing, because there's a couple of reasons I've done this 180 from when I was growing up, right? Because I saw what the opportunities were that were available for me. And I worked so hard at nursing school because I was desperate. I needed to be able to take care of this child.
Mhm.
I had a baby and I had to take care of that baby. And I spent a long time thinking, what do I want to get my master's in nursing? I had left the bedside. I know we were chatting about this right before our meeting, so I don't mind sharing. One of the reasons I left the bedside is because I lost my hearing. I am bilaterally deaf, and there are deaf nurses who work the bedside. They absolutely can. I have a cochlear implant, but I did not feel comfortable working the bedside anymore. I did not feel I could serve people the best working at the bedside. And so I thought for a while, it's like, what do I want to get my master's of nursing in? I really don't know what I want to get my master's of nursing in. And I ended up getting an MBA. Part of that is because I work in a business field right now. I felt it was more marketable. And don't tell my husband. Hopefully he never watched the video. But again, I have looked to see, but I still love being a nurse. I still want to continue my education as a nurse. And the only MSN I'm really currently interested in getting right now is one in nursing education. There's a reason it's hard, just like we were discussing why women are historically paid less in teaching. The nurses that are historically not paid very well are nurses who teach. Because part of that nursing shortage is not enough faculty because they're not making an awful lot of money. And so I had some of the best nursing faculty members in the world at Durham Tech and at UNCG. Absolutely. Hands down, some of the best, but most of them had reached the end of their clinical career, and that's why they went into nursing. Or nursing education. So you're looking at a pretty short-lived, usually. These are not people who are going to be nursing educators for 25, 30, 35 years. They may do it for another, 5 or 10 years, and then they're retiring to enjoy their life as they should. But no, I've been eyeballing MSN in education. Because you get so buried in the taking care of patients and learning about the disease state and learning about the drugs. And if we don't pass that knowledge on to somebody else, like one of my best teaching experiences, I'll tell you this really quick. I promise I won't keep you too long with chatter. I was taking care of a patient, and she was an elderly woman. And I don't know if you've ever had the experience of having Tegaderm on you, but Tegaderm is like a Band-Aid without a little pad, right? So it's usually a clear plastic film.
Yes, I've had, like they put around the IV or something. You have one in your hand, and someone.
Yep.
Yes, I know what that is.
So if you are very elderly, or if you're on certain medications, taking that Tegaderm off will rip your skin right off.
Yes,
very bad. So I was taking care of an elderly patient, and I was taking out an arterial line, and it was secured with a Tegaderm, and I was using I can't even remember the name of it, but it's a type of solvent or dissolvent, really, and it would break down the adhesive. Yeah. And I'm slowly pulling it off, and her granddaughter was in the room, and I'm explaining it to her because you're a nurse, you're a teacher, and she was very interested. She told me she was going to go to nursing school. Mm-hmm. She's like, "What are you doing?" And I explained all that to her, and I said, "I understand this looks like I'm taking a long time. I'm not trying to torture your grandmother, but I'm trying to protect her skin because it would hurt and it would take a long time to heal." Mm-hmm. She was like, "Yeah, no problem." I get the Tegaderm off, we take care of grandma, we get her transferred to the floor, everything's fine. A couple of years later, I'm still working in the same ICU, and I get a transfer from the ED. I get the patient, I get him set up in bed, I'm talking to the ER nurse, and she says, "Do you remember me?" And I said, "I'm sorry, have we crossed paths at work?" I don't. And she goes, "You took care of my grandmother. Oh. And you took the time to explain to me what you were doing to get that Tegaderm off without ripping her skin." And she goes, "And I do that with every patient now."
That's amazing.
Because you took the time to not only explain it to me, so not only do I do it, but I explained it to the patient or I explained it to their family. And I went, "Oh, yes, I do remember that." And And it's things like that that was very empowering as a person. It was very empowering as a nurse to realize something I had taught somebody had that trickle down effect. Because I guarantee you, she taught another nurse that,
Yeah,
and they'll teach another nurse that.
yeah, absolutely. Well, thank you so much for chatting with me today, Sharon. This has been absolutely lovely. I've learned so much. I may have to come back and get some more information, so you'll come back and join us for another chat later on. And I must say, I am very proud of you for having lost your hearing, or a good portion of your hearing, and not letting that impact your career and your future. So I'm very proud of you for that. Thank you.
I didn't work for a little bit. I lost my hearing and we were looking for solutions, beyond hearing aids. And this is my last story. I promise. I promise. And then I ran into one of the doctors I worked in the ICU, and the mall of a park. It was in the parking lot at South Point. And he's like, "Hey, I haven't seen you around." I said, "Oh, I'd had another son at that point." And I said, "Actually, I've gone deaf. I've lost my hearing. So we're trying to figure out what we can do." And he said, "Oh, that's a shame. You were one of the best nurses I ever worked with." And I
Mhm.
was really sad because it was really bummed. Like, I lost my whole career. Like, I had really done all this work to get this career, and it felt like it was ripped away from me. And I thought about that for a couple weeks. And then I sat up in bed one day and I said, "You know what? I still am a really good nurse. I'm not like a has-been. Like, I'm still a really good nurse. I have to be a nurse in a different way.
Yeah,
And that's okay. And I can do that." But that was a really pivotal moment for me because I did feel that I was really depressed. I was really sad. And he was like, "You were one of the best nurses I ever worked with." And I was like, "I'm still a good nurse." What do you mean? What I was one of the best nurses, but
ec-
and
do you,
that's why I pivoted my career.
excellent. Do you sign?
You know what? When I went to UNC Greensboro, I actually took sign language. And at the time, I had a bone anchored hearing aid. Like, now I have a cochlear implant, but I had a bone anchored hearing aid. And I would take it off during class so I could learn. But the problem with sign language is you use it or you lose it, right?
Right.
And nobody else in my family knows how to sign. So I know a little bit. And I teach people who report to me the two most important signs, which is yes
Yes.
and no. Yes and no.
Yeah.
And so we'll be in meetings, they'll be saying something, I'll be like, no. Yeah, so I do know some signs. And I did very well at it in college, but I need to practice more.
Yeah.
Um,
My brother, I was adopted and raised by a paternal aunt. Her son is totally, he doesn't speak or can't hear. And when I was younger, I could have hours of conversations. Today, I might get 5 minutes in conversation. That's why I asked. But that's wonderful. Thank you again, Sharon. This has been absolutely lovely. Again, like I said, I've learned so much, and you tell the story so well. So thank you for chatting with me.
well, thank you very much. I hope you have a wonderful, if it is a holiday for you, I hope you have a wonderful holiday. And
What
I imagine
holiday? President's Day?
it's President's Day. So I know some people are off and some people aren't, but
Uh,
um my husband has probably gotten into something because we moved into a new house and now he keeps like fixing things. I'm like, it's a brand new house. There's nothing to fix, but here we are.
well, again, thank you so much for that. And please stay in touch. As soon as the video converts, I'll send you a link. Please watch it and let me know if I may upload it.
I will be happy to watch it, although I feel weird looking at myself on video, but I've done it before. So I will dig deep. And it's been a pleasure talking to you. And I am happy to chat with you anytime. We have all kinds of stuff. We have disability diversity, married to somebody, of course, who is Asian, and we have biracial children. So we have quite the experience all around.
Excellent. Well, thank you again so much. And I look forward to talking to you very soon. Stay
All right.
well. And if I can help in any way, please let me know.
You'll hear from me. Thank you very much, Dr. Newton. Have
Thank
a
you.
good one.
You too.